Yeah, very good evening to all of you from Bharat Serums and Vaccines. I am Reshma Patil, and on behalf of Bharat Serums and Vaccines and Kenya Obstetrics and Gynecology Society, I welcome you all to this webinar on the occasion of World Endometriosis Awareness Month. We will be having a session with our international speaker on the topic leuprolide acetate and effective treatment strategy for endometriosis. I would now like to welcome Dr. Kereki to address this forum. Dr. Kereki, over to you.
Thank you. Thank you very much, Reshma. Thank you, Bharat Serum. Good evening, everybody. And thank you for coming. Thank you for taking time off your busy schedules to come and share with us this evening and this topic. As Reshma mentioned, March is Endometriosis Awareness Month, and you will notice sometimes some of the women, maybe in town or wherever it is, some of the nurses in different hospitals, they may be wearing a yellow ribbon on their chests. This is basically to show solidarity with those patients who could be suffering or have suffered from endometriosis. We know that it is an enigmatic disease, enigmatic in the sense that the more we think we know it, the more we don't know. We don't know much about the pathophysiology, even though there are many hypotheses of how it could spread, because some of those hypotheses do not actually explain the presence of endometriosis in different parts of the female body. We don't know, we know much about how to treat it. And unfortunately, the more we treat it, sometimes the more it comes back. So it is a big problem. We know that it affects about 10% of all the women who have issues with infertility. It affects all ages, unfortunately, from adolescence through the reproductive period. It affects women, especially in infertility, as I mentioned, but then psychologically as well, and socially. So it is a problem which is in our midst. A recent paper a few years ago say that in Europe, it took about 10, 11 years from symptoms appearing in an adolescent to proper diagnosis of endometriosis. In other parts of the world, in the developing countries, it may take longer. So today it is good that we have this topic that we are going to talk about. And apart from discussing about endometriosis, we also create awareness to the public such that they may have an idea, they may know that this disease is there and what to do about it. So as a pointer, we are going to have Dr. Basma, whom I'll introduce later on. But a bit of housekeeping, please switch off your mics, and there will be a box there, where the chat box, where you can post your questions and your comments, which we'll use them later on. We retrieve them for the speaker to answer them. Over to you, Reshma Patil.
Thank you, Dr. Kereki. I would like to take this opportunity to take you through a corporate presentation for Bharat Serums and Vaccines. So at Bharat Serums and Vaccines, we have a world-class expertise. We have R&D in our genes, and we are pioneers for over 4 decades in developing and commercializing innovative products, which are driven by cutting-edge research. We have state-of-art manufacturing facilities that is WHO GMP certified and as per the UK MHRA guidelines. We have R&D in our genes, and we have R&D units in the USA, Germany, and India. We have a US subsidiary, which is called as BSV Biosciences Inc. This one is focused on developing recombinant proteins and monoclonal antibodies. We have a German subsidiary, which is also called as Biosciences, BSV Biosciences, GmbH. This is focused on protein-based therapeutic product development. We have an R&D center in India as well, which focuses on biotech process development, biological product and process development, and NDDS product and process development. We have many research credentials to our kitties. We have an experience of over 4 decades in developing and commercializing innovative products, which are driven by cutting-edge research. In biologicals, we were the first one to introduce equine rabies immunoglobulin, antithymocyte globulin, and urinary trypsin inhibitor. In the biotech category, we were the first biogeneric RFSH in India, and we were the first ones in the world to market monoclonal anti-D immunoglobulin. We were the first in the world to market monoclonal tetanus injection, and we were the first biogeneric for developing recombinant HCG in India. In the novel drug delivery systems, we were the first ones to market propofol emulsions and non-pegylated liposomal doxorubicin, amphotericin emulsions, and many more. We have a very healthy patent portfolio at Bharat Serums and Vaccines. We have more than 15 product patents in India as well as internationally. Internationally, the patents are granted in India, USA, Europe, Australia, South Africa, and Russia CIS. We have a state-of-the-art manufacturing facilities at India, at Germany. We have the Indian facilities at Ambernath and injectable plants, which have 4 dedicated injectable lines, and this is built as per the UK MHRA guidelines. We have an oncology plant in Ahmedabad, which is dedicated for liposomal and liquid oncology products, and this is approved by the German GMP audit. We have biological API plant in Germany at Baselware, and this is dedicated for the hormones, API of the hormones and other biological products. This again is successfully audited by the German authorities for GMP. We have a biotech plant at Ambernath, India, which is dedicated for biological and biotech products. As I mentioned, we have the BSV manufacturing facility at Ambernath, which is commissioned in 2011, and especially for biotech and biological products. And this one is dedicated for the emerging markets. We have the bulk biological plant in Germany, which has a team of over 25 people and successfully audited by the German authorities for GMP. At Bharat Serums and Vaccines, we have Indian operations as well as international operations. The sales and marketing infrastructure at Indian operations is with the local sales team of more than 1,000 salespeople, products ranging from gynecology, ART, neurology, hematology, emergency medicine, and critical care medicine. We have products distributed through 26 carrying and forwarding agents with more than 1,500 stockists across the country. At international operations, we have marketed the BSV range of products in more than 50 countries. We have regional offices in CIS, Russia and Ukraine, in Africa and Asia. We also have a 100% subsidiary at Philippines, which is called as BSV Biosciences. At international, we have dedicated support teams, which includes the logistics, supply chain, regulatory, marketing, and medical affairs. We have many awards and recognitions to our kitty. We were ranked as the top 10 biopharmaceutical company by Biospectrum and ABLE. We were also ranked as the fastest growing Indian biotech company by Frost and Sullivan in 2012. We offer a very sophisticated range of product in the women's health category, right from the comprehensive gynecological care, from conception to delivery. In assisted reproductive techniques, we offer products from down regulation to providing a luteal phase support. We are often called as the one-stop solution in ART because we believe turning IVF ratios in favor of success. And we are the basic manufacturers of gonadotropin since 1998. And we are the only company to manufacture all the 3 generations of gonadotropins, be it urinary, highly purified, and recombinant gonadotropins. We offer a highly pure range with the products UPOG, UMOG, and Folliculine HP. We have recombinants in the name of Foligraph, and we have GnRH analogs in the name of Luprodex and Asparalex. Coming to Luprodex, which is a GnRH agonist, we have a 3.75 mg injection, particularly indicated for endometriosis, fibroids, and downregulation in ART cycles. And this product is developed by world-class research team and has an ideal microsphere technology, which is indicated for endometriosis and fibroids. With this, I would like to thank you for your attention and would also like to take the opportunity to introduce Dr. Kireki. He is the moderator today for our session with the international speaker, Dr. Basma Darwish. Dr. Kireki is a consultant obstetrician and gynecologist and a fertility specialist. He's currently serving as the president of COGS, Kenya Obstetrics and Gynecology Society. Dr. Kireki, thank you for accepting our invite and moderating today's session. Over to you.
Thank you very much, Reshma. And we dive straight away into the topic of our discussion today. That is lupride acetate, an effective management strategy in endometriosis. The person who's going to present this is none other than Dr. Basma Darwish. Dr. Basma Darwish, is French board qualified in obstetrics and gynecology. She has a fellowship in surgical and minimally invasive surgery, that is laparoscopy or keyhole surgery in gynecology. She's also a consultant obstetrician and gynecologist and works for the Bahrain Defense Forces, Royal Medical Services at a military hospital. Apart from that, she has a special interest in laparoscopic gynecology, taking care of high-risk pregnancies, and apart from that, also doing other minimally invasive surgeries like hysteroscopies. So Dr. Basma Darwish, you didn't tell us whether you have a military rank, but that is okay. So the floor is yours. Thank you very much for accepting to be our teacher today. Dr. Basma, welcome. Thank you.
Good day, Dr. Kireki. Thank you very much for having me. It's a pleasure to be here among you all in this Endometriosis Awareness Month and this day especially. And whether I have a military rank, unfortunately, I do not. So I'm a civilian who works in a military hospital. Okay, so in this Endometriosis Awareness Month, I would like to start by saying, just because you can't see it does not mean it does not exist. So if I'd ask you to look around and count 10 women, or maybe think about 10 women you know, a sister, a mother, a friend, an aunt, or a cousin, it's almost probably certain that one of those 10 women will suffer from endometriosis. Jacques Donnez, one of the pioneers not only in gynecology, but in endometriosis specifically, once said that no woman is born with stage 4 endometriosis. And the image you see on the screen represents the probable natural evolution of endometriosis. Adolescents will have at least minimal lesions of peritoneal endometriosis initially identified as stage 1 or superficial endometriosis. And in many cases, these lesions may remain minimally symptomatic until the onset of menopause, but in other cases, they are only an intermediate stage towards more severe forms of ovarian endometriomas or even deep infiltrating endometriosis. And finally, in some cases, the appearance of the lesions does not change significantly, but the patients complain of multiple pains. Logic and clinical intuition would tell you that a woman that has a normal pelvis without any anatomic lesions should be pain-free. And the woman here with stage 4 endometriosis should be the one that is experiencing the most pain. But any of you who regularly treats and sees women with endometriosis knows that this is not necessarily true. There are a significant amount of women that have very advanced endometriosis with very little pain at all, and many women that have significant pain without any pathologic findings. And here is the classic picture, which you probably know, and maybe unfortunately too well. It would be this pain that patients would describe as a terrible pain during cycles, and not that type of pain, of course, for which they can take a simple painkiller, lie down, rest, and it would go away, but that type of pain that would knock them down. Successive visits to doctors, and with time they would develop new symptoms, GI symptoms like nausea, bloating, fatigue, migraines, a constant battery of tests, blood work, CT scans, MRIs, endoscopies, colonoscopies, and everything would come back normal. While there is a lot we know about endometriosis, we may know that maybe what is likely is that retrograde menstruation plays an important role. We know that implant proliferation, neovascularization are very significant factors in the underlying pathophysiology of endometriosis. But to be quite honest, we really do not understand why it is that these issues may or may not lead to pelvic pain in certain women. The most simple and logical way would be to assume that endometriosis is a nociceptive pain condition. And nociceptive pain is defined as a condition in which pain occurs as a result of injury or inflammation to the outside body. And that injury or inflammation is perceived as it travels through the spinal cord up to the brain to give a perception of pain. And it is also quite logical that endometriosis should be able to do this, because it has been well established that endometriosis, yes, involves direct infiltration of nerve fibers. There is increased inflammatory markers, increased inflammatory cytokines that stimulate those nerves, and there is nerve cell proliferation. This model of nociceptive pain is very well understood, and it is the underlying physiology of many acute pain issues, such as acute surgical pain, but we know that increasing evidence suggests that this model is really insufficient to explain the experience of chronic pain in women with endometriosis. The interview with these patients remains quite complicated, and I always insist on the good news. So in patients with painful peritoneal endometriosis, I try to tell them that your fertility is not affected in stage 1 endometriosis. You might not need to undergo complicated surgery or any therapeutic surgeries, but I have to tell them about other less good ones, that it might be very difficult for us to get rid of your pains. The pain can get worse and affect different organs. They risk always having more or less pain until menopause. And in case of associated adenomyosis, hysterectomy is possible in the future. So what are our treatment options? Yes, maybe medical and maybe surgical. Surgery is effective, especially in cases of severe endometriosis, where the patients most often see a clear benefit in terms of pain and spontaneous fertility. But on the other hand, in case of superficial endometriosis, the interest of surgery is much more debatable due to transient and short-term efficacy. During a laparoscopy in a patient with superficial endometriosis, you might observe different types of superficial lesions. You might see some red spots, white stars, coffee spots, peritoneal pits, some hypervascularized areas, black cysts, a bulky uterus, which is soft to touch with a much more rounded surface posteriorly than the anterior surface, and maybe some round ligament insertions which are displaced forward. Unfortunately, the surgical treatment of these superficial lesions has a minimal impact on the pain, and everyone can verify this by seeing the patient again, maybe 1 year later. So it must be said loud and clear that a patient with stage 1 superficial endometriosis can be as, if not more painful than a patient with stage 4 endometriosis. because the 4 stages of endometriosis are predictive of spontaneous fertility, and they have no correlation with the intensity of pain. Maybe you have probably already realized that patients with extended forms, high inflammatory disease, are not good candidates for surgery. Large peritoneal resections provide only short-term benefit, and the recurrence of pain is constant a few months later. And those are the type of patients who could benefit more from continuous medical treatment, which aims at suppressing menstruation and therefore inflammation. So what is the role of medical treatment? The main role would be to control the symptoms. There is evidence that endometriosis can be suppressed by these medications by downregulating this active disease and causing inflammation to regress. Medical treatments can also be used in the preparation for surgery, maybe limited to a time between 3 to 6 months before a surgical procedure, and this results in less bleeding and makes the surgery a little bit easier for the surgeon. And we recommend medical treatment after surgery for regression of the disease, and in some cases before IVF for a short period of maybe a few months before a fertility treatment. There are various types. Simple pain medications fall into the first group, and these are really common things like paracetamol and non-steroidal anti-inflammatory drugs like ibuprofen, diclofenac, etc. And these can be really very effective in managing pain, but unfortunately, they do not get into the heart of the disease, and so they will not stop the active disease from progressing. Opioids could be an option, even though I would say less likely when it comes to non-cancer treatment, because especially one of the side effects is constipation, which can make symptoms even worse in patients with endometriosis, and of course, dependency on the other hand. Hormonal medications are mostly contraceptives or gonadotropin-releasing hormone analogs. So the hormonal treatments used to act on endometriosis and stop its growth. What they do is either they put you in a perimenopausal state that is similar to pregnancy, and they all have a contraceptive effect, so they're not suitable for those who want to get pregnant, unless there is need to take it before medically assisted treatments. Most of them will be similar in their effect in treating endometriosis, so the choice is based on how well a patient tolerates some of their side effects. Combined oral contraceptives is one of the most common contraceptive methods. They contain both estrogen and progesterone, but in a synthetic form, and they resemble female hormones, which are naturally produced by the body. So what these do is that they stop the menstrual cycle completely, and they inhibit ovulation, which is really an important part of controlling endometriosis. They also suppress the amount of estrogen in the bloodstream, meaning that they do work well in suppressing endometriosis implants and sometimes also obtaining some regression of the disease. One of the best ways of managing endometriosis is to limit the number of menstrual cycles or to completely suppress them. So you can do this with the combined oral contraceptive by taking the packs back to back. But one of the side effects of doing this is spotting or some withdrawal bleeding. And this is where I recommend what I call as the flexible extended use. And what I mean by this is that the pill is taken continuously until a woman experiences some important spotting or a withdrawal bleed. And at that moment, the pill can be stopped for a duration of about 4 to 5 days and restarted thereafter. And I always tell my patients that having maybe 3 to 4 cycles per year is maybe better than having 12 cycles in controlling their symptoms and in controlling the progression of the disease. Progestogens are another type of hormones that would also mimic pregnancy. And what happens is that they replicate the normal female hormone progesterone, but in a synthetic manner. And what it does is that it causes the endometrium to thin out, which is very similar to the endometriosis implants, and it causes them to completely regress and become very inactive and stop growing. And that is why about 40 to 60% of women do not get any periods with progestogen treatment. And these are usually taken continuously, and they're very safe to take up to menopause. Some progesterones which are available in the market are as follows. We have the Desogestrel, which is one of the most common mini pill. And these are tablets that you take every day with no break. And most women do not have a period with it, or they might experience some light, painless bleeding. On the other hand, we do have the hormonal intrauterine contraceptive devices, and this is another common progestative method. Usually, intrauterine contraceptive devices are licensed for 5 years for a contraceptive label, but in those with endometriosis, maybe it needs to be changed earlier because progesterone does start to wear off towards the end. And keep in mind that progesterone IUCDs fail to inhibit ovulation in the majority of cases. And as I said before, inhibiting ovulation is one of the important things to obtain in order to stop the symptoms of endometriosis and also try to stop the progression of the disease. Medroxyprogesterone injection or tablet is also another option. And then we have a newer progesterone tablet, which is the Grenadotropin. And this is not very different from other progesterones, but it probably has lesser side effects when compared to others, and it has been designed specifically for endometriosis. Yes, it stops ovulation, so it is also a contraceptive, even though it is not licensed as such. And one of the main side effects is vaginal spotting. You should also keep in mind that it seems to reduce the bone mineral density. So you should use it in caution for long-term periods without follow-up or the use of add-back therapy. Now we move to drugs that mimic menopause. And these drugs tend to be more powerful and strong. They stop the production of the hormones FSH and LH, and they cause the ovaries to switch off, and it temporarily causes the ovaries to stop producing follicles and completely reduces estrogen. So this results in the endometrium and the endometrial cells not to grow, and the periods will stop completely with this treatment. This is usually given as a 3.75 milligram 1-month injection or an 11.25 milligram 3-month injection. The reason why those treatments are such good medications is because they drastically reduce estrogen levels very quickly, and that gives patients really rapid control of their symptoms. Even patients with severe symptoms might be able to keep resolution of their symptoms within weeks with such a treatment. The downside to the medication is that the low estrogen can result in quite disturbing menopausal side effects, the most important being hot flushes, night sweats, mood disturbances, and thinning of bones, as demonstrated on a bone mineral density test, somewhere around 20 weeks or 6 months after treatment. Nowadays, what we do and what is recommended is an add-back therapy, or in other words, a hormone replacement treatment alongside the injections in order to make use of this useful medication to improve the unpleasant symptoms, to improve the quality of life, and to maintain bone density. So there is no evidence that giving hormonal replacement treatment with the injections flares up the disease and does not treat endometriosis. To note also that the side effects, if present, are temporary and they usually wear off a few weeks after treatment. Even though guidelines recommend the use of analogs for a duration of 6 to 12 months in order to reduce the impact of side effects, you might sometimes need in certain cases to prolong the treatment, especially in women approaching menopause who would want to avoid surgery that might include hysterectomy and bilateral adnexectomy. So if we're looking at a longer term treatment, what we recommend is an add-back therapy alongside and a follow-up of bone mineral density every 1 to 2 years. Gonadotropin releasing hormone agonists being one of the oldest FDA-approved medical treatments in the market and one of the most widely used for the treatment of endometriosis in human beings, has been largely studied in adults. Coming back to young girls in their adolescence and by understanding the natural history of endometriosis, we believe that endometriosis may only start by minimal lesions at that age, where surgical intervention plays no treatment role, whereas medical treatment in this group of young teenagers is the most ideal treatment that not only resolves symptoms, but might also suppress disease. So medical treatment nowadays is being more investigated in such an age group. Diagnostic surgery is usually not necessary in such an age group, and empirical first-line hormonal treatments like oral contraceptives and progesterones can be used. And it is only upon failure of the first-line treatment that a surgical diagnosis is necessary before initiating the second-line treatment, which is the GnRH analogs, which have been now in a number of articles studied, especially by the group of Gallagher and his co-workers, who have reported about their investigations on the effectiveness and safety of GnRH agonists, of course, with an add-back therapy in adolescents. And in the study of De Vesta in 2015, he has reported that almost 50%, so about 48% of the young women in this age group rated the GnRH agonists plus add-back therapy as the most effective hormonal medication for treating endometriosis pain. In adult, GnRH analogs have been widely studied, and literature shows its superiority on other medical treatment methods, especially in times of relapse or failure of first-line treatments. And now it is clear that an associated add-back therapy allows for a longer therapeutic duration, up to 12 months in most studies. Deben Wu and his team have shown that add-back therapy does not reduce the efficacy of using GnRH analogs for the management of endometriosis. And in a randomized controlled trial by the team of Zuppi, they have shown that add-back therapy allows the treatment of women with relapse of endometriosis-associated pain for a long period more safely, with limited bone mineral density loss, with a good control of symptoms and better quality of life compared with GnRH agonists alone or compared with oral contraceptive pills. I spoke at the beginning of my talk about pain physiology, and that it is not very well understood in the patients with endometriosis. It is as if the same stimulus would not trigger the same bell in a normal woman as it would in a woman with endometriosis. And one of the reasons that would make us believe in this is, well, first, as we talked about earlier, there is little of any correlation between the extent of disease and the severity of pain. And second, medical therapies that are directed specifically at the endometriosis lesions are non-specific, and they actually treat many other causes of pelvic pain. So for example, one of the FDA-approved treatment for endometriosis, which I've just spoken about, is the GnRH agonists. They have been proven, or they have been seen to be effective therapies for actually many other conditions, including cyclic irritable bowel syndrome and pelvic pain without endometriosis. So what pain physiologists suggest is that in these patients that have chronic pain, there is some sort of imbalance in the central nervous system, such that there is either or a combination of increased facilitation or maybe a decreased inhibition that is associated with this state of chronic pain. For patients with stage 1 endometriosis or peritoneal endometriosis, I practically no longer use the term endometriosis, but that of chronic pelvic pain, which seems to me to be much more representative of what is happening in their body. Because the clinical picture is much more complex, and superficial endometriosis represents only a very small piece of the puzzle, because it is most of the time associated with other conditions. Most common of them are interstitial cystitis and irritable bowel syndrome. So urinary symptoms are common. Imaging does not find any bladder endometriosis lesions because the real cause is the bladder pain syndrome. And these symptoms are usually permanent, but with a noticeable worsening during menstruation and in the form of several urinations, so frequency, day and night, and the impression of never completely emptying the bladder. So there is a state of a bladder or urinary hypersensitivity, or maybe an overreactive bladder. Similar painful symptoms also concern the digestive tract, without any imaging or laparoscopy findings of digestive endometriosis lesions, and they seem to resemble that of an irritable bowel syndrome, and they also increase, of course, with cycles. We studied the frequency of digestive symptoms in patients with painful superficial endometriosis, and in reality, the vast majority of chronic painful pelvises, and we observed a high frequency of more than 30 to 40% of them experiencing diarrhea, dyschezia, constipation, and sometimes symptoms that are comparable with those encountered in women with deep or colorectal endometriosis. And this means that the presence of digestive symptoms in a patient with endometriosis does not always mean that one should automatically suspect a colorectal endometriosis nodule. And this is where a multidisciplinary approach comes. And this is where also continuous medical treatment, and maybe especially a gonadotropin releasing hormone agonist, which seems to work even though not necessarily targeted at only endometriosis lesions. So of course, we work as gynecologists to manage those patients. We work with gastroenterologists in order to manage the symptoms of the irritable bowel disease, with urologists to manage the symptoms of interstitial cystitis, specialized pain centers that can offer neuropathic medications, nerve blocks, acupuncture, and then pelvic floor physiotherapy, which seems to work quite well in those patients, and they help to release this muscular tension. And then, of course, not to forget some cognitive behavioral therapy, which is also important in those patients who suffer from chronic pelvic pain. When surgery is necessary, and this is mainly in cases of deep infiltrating endometriosis, which might involve the rectum, the vagina, the bladder, the ureters, or even the diaphragm. Of course, here we're out of the scope in this talk to discuss the indications of surgery, but when a surgery is required for the treatment of advanced deep endometriosis, studies are limited, but there is strong expert recommendations that acknowledge the use of preoperative gonadotropin releasing hormone analogs for a short period of time in preparation for surgery, because this seems to reduce inflammation and facilitate the surgery. So I myself and the team with whom I worked would never operate on deep endometriosis without at least a 3-month period of GnRH agonist preparation, which can sometimes be extended up to 6 months in preparation for surgery in very severe and expected to be challenging surgeries. I'm also one of the believers in that medical treatment of endometriosis post-surgery is an obligation rather than a mere option. So the team of Haras Rahman, my always mentor in the field of endometriosis, has just released the results of a 7-year follow-up of women who have been operated for rectal endometriosis. And the study reported long-term satisfactory digestive function. There is an overall risk 7 years after surgery of rectal nodule recurrence of about 3.5%. And the risk of reoperation, mainly for pain relapse, was about 14.5%, and in whom about 26% of them were required for reasons of IVF management. That is, those were the patients in whom continuous medical treatment was interrupted. So in severe deep infiltrating endometriosis surgeries, GnRH agonist is preferred to be continued initially for a few months post-surgery, because this is the most powerful in reducing inflammation, and then can be followed with any other medical treatment of choice. To bring some new data to the topic, I would like to share with you our experience in managing a 41-year-old patient who presented to our department with a 6-centimeter endometriosis nodule in an episiotomy scar. So she had given birth twice before, 18 and 13 years before, and always with an episiotomy at each time. So a year after the second delivery, the patient felt a small swelling in the episiotomy site, and 10 years later, when she completely abandoned contraceptive pill intake, she observed that there was a rapid growth of the swelling, which later became larger and more painful during menses. So gynecological examination revealed a solid tender mass, about 5 to 6 centimeters in diameter on the episiotomy site that was quite close to the internal anal sphincter, and biopsy of that lesion revealed multiple endometriosis foci surrounded by some fibrous tissue. So the MRI image is the one you can see on the left side, and this showed a large endometriosis nodule of a diameter of about 6 centimeters, and an endorectal ultrasound revealed a mass in close contact with the anal sphincter, but with no infiltration. So we thought that maybe a wide excision in this patient would have led to an uncertain aesthetic and maybe even functional result. So we thought of proposing a first-line medical treatment by gonadotropin-releasing hormone agonists, and of course associated with an add-back therapy to induce a prolonged therapeutic amenorrhea. And then you can see the image on the right is 3 months later, where the patient was completely pain-free, and then the treatment was prolonged for another year. So following this, the patient was reviewed yearly with a follow-up MRI before every visit and with clinical examinations and assessment of bone mineral density. So MRI examinations showed progressive and significant reduction in the nodule size, as we can see in this image, and this was obtained at 3 years following medical treatment with a gonadotropin-releasing hormone agonist. And we were capable, as you can see also in the chart, to obtain a reduction of about 33% from the baseline volume initially when the patient came in. The bone mineral density was assessed also yearly, and this showed unchanged normal results. And 3 years later, the patient was asymptomatic and did not experience any adverse effects. And you can see the images 3 years later, and this is where the clinical examination showed a significant reduction in the tumor size, and there was absence of tenderness on palpation. So at this moment, the nodule size had reduced significantly, and this could have allowed for a probable, less morbid surgery, but due to the patient's desire, because she was in total satisfaction and because of the positive results she obtained for the medical treatment, she decided to carry on the therapy up to menopause. Because the high cost of the injections and because we were able to obtain maybe similar results, we continued the treatment with progesterones thereafter. And from this, case report, we can see that the gonadotropin-releasing hormone agonist was administered for 3 years, so for a prolonged period, and was followed by significant regression in the nodule volume, as I said, about 33% from the baseline value. And this is not the only study, of course, it's just a case report. But in a recent randomized controlled study by Angioni and his team, he has shown that gonadotropin-releasing hormone agonist administration in patients with incomplete resection of deep endometriosis allowed for an improvement in pain similar to that recorded in women with complete surgery. On the other hand, we do know that those favorable outcomes usually disappear shortly after finishing treatment. So this leads to a conclusion that the medical therapy is valuable when the main goal is to reduce symptoms, especially when resection can lead to unsatisfactory results, but this is when it is administered continuously. And when we need, to stop the treatment, then either the symptoms or maybe the nodules can progress again. The major adverse effect of gonadotropin-releasing hormone is the loss of bone mineral density, and therefore that is why it is sometimes recommended as a second-line therapy, and the administration is limited from 6 to 12 months in order to prevent the side effects associated with it. But I mentioned before that there are also various studies that have used the gonadotropin-releasing hormone agonists in combination with add-back therapy for a long period of time with no adverse effects. So on this basis, we can say that exclusive medical therapy can be used up to menopause in older patients presenting with deep endometriosis, in which maybe wide excision can lead to unfavorable functional or aesthetic outcomes. And when a gonadotropin-releasing hormone agonist therapy is administered, we usually recommend to perform a yearly assessment of bone mineral density in order to evaluate the absence of risk of osteoporosis. To date, in our series, no patient has had medical treatment disrupted due to abnormal bone mineral density results. And finally, again, with the team of Horace Roman, we have a randomized controlled trial called MEASURE, or in French, MESURE, which compares the efficacy of medical and surgical treatment in rectal deep infiltrating endometriosis where we have enrolled patients over the age of 35 without pregnancy intention who have rectal endometriosis. And those women were, of course, distributed into two groups. First group managed exclusively by medical treatment, and this first group will be compared to another group in which this group will be managed by surgery and post-operative medical treatment. So the results will be analyzed in terms of digestive outcomes, gastrointestinal quality of life, and improvement of pain. So the patients have already been recruited, still a year more to go for the results to be analyzed, and hopefully I can come up with the results for the next Endometriosis Awareness Month in 2023. Thank you.
Thank you very much, Dr. Basma, for that. Quite insightful and quite interesting. By the way, your slides are very clear and they're very descriptive, easy to see, easy on the eye, and beautiful to digest. Thank you. Thank you for that. We have quite a number of questions in the chat box, but before we go there, maybe one or two questions to you, Dr. Basma. One of the things that you mentioned a few seconds ago is that what you have observed is that medical treatment can be used in deep infiltrating endometriosis without having to go for surgery. And what about cases where you have a frozen pelvis? Is that also included there? And what is your experience with that? That is number one. Number two, right at the beginning, we talked about endometriosis diagnosis in adolescents and so on. I know Bahrain is a small country in terms of population. I don't know how, in terms of equipment, in terms of personnel, where we can grade it, and how often you see adolescents with endometriosis, and how easily it is for them to access specialists like you, for example, because we do have a problem in in this part of the world. Maybe we can start with that.
Yes. So, as we said, as Jack Donnez said, that, nobody is born, of course, with a stage 4 endometriosis. So this is our aim. Our aim would be to catch the disease very early. And if we can catch it in the adolescent stage, that would be good, because if we start treatment early, we would be able to resolve the symptoms and we would be able to control the progression of the disease. And as we said, we do not very much understand the pain physiology, but from a peripheral pain, it could lead to a centralization of the pain and to a chronic pelvic pain. The system in Bahrain is a small country, so the health system is quite well organized. The first liners would be the family physicians. So, patients usually have easy access to the family physicians, and usually upon the minimal suspicion of any pain during cycles, so dyspareunia, which is out of the normal, usually they have a direct consultation with a specialist, so a direct referral with a specialist. And the delays, because maybe Bahrain is a small country, the delays and in our hospital is not more than 2 weeks.
Wow, that is beautiful. I think that could be the standard, should be the standard. Then we'll have this problem or this enigmatic disease, sort of wiped out. Thank you very much. Now, on the chat box, we have a few questions there. We'll start with John Njoroge. John Njoroge asks, is there any relationship between ultrasound diagnosis and hemorrhagic ovarian cyst? I'm not very sure what exactly Dr. John Njoroge would like to ask, but this is what he's asking. Any relationship between ultrasound diagnosis and hemorrhagic ovarian cyst? What do you think, Dr. Basma?
I'm not sure if it is how we can differentiate maybe between endometriosis and hemorrhagic ovarian cysts. So, yes, we can differentiate between endometriosis and hemorrhagic ovarian cysts by the way they look. because a hemorrhagic ovarian cyst is usually a fresh cyst. I mean, it is fresh blood. So if we see it on ultrasound, we will see something like lace-like. So we'll see like strands which are hyperechogenic, so like white strands, lace-like, I call them, which are usually typical of a hemorrhagic ovarian cyst. We can sometimes find a single blood clot in the middle of a cyst, and this is usually significant of a hemorrhagic ovarian cyst. Whereas on the other hand, endometriomas, because they are chocolate cysts, so we're talking about old blood that has been there for quite some time, and there is a typical appearance of endometriomas, and this is what we call as a ground glass appearance. So usually it is more homogenic, it involves the whole cyst, and it has this ground glass appearance.
And I think once, Dr. John Njoroge, once you see these 1 or 2 pictures of that ground glass appearance, it sticks in your mind. And every time you do a scan and see that, obviously, as the adage says, the mind does not know what the eye, or is it the eye cannot see what the mind doesn't know?
And
so
another
once you
tip
see,
maybe, sorry.
Yes, go ahead.
I was saying just another tip maybe to help out, if you cannot very much differentiate between the two, because for example, you're just starting. So I would advise follow up, because in the majority of cases, if we just have a hemorrhagic ovarian cyst, it would disappear with time, maybe a maximum of 3 months, and it would be gone. Whereas an endometrioma would be persistent. It would rarely go without any treatment.
Or it may even grow bigger with time, unfortunately. Yeah, thank you very much. Dr. Mwangi Karanja, very interesting question here, and I think we can dwell on this a bit because this is sort of my passion. I want to hear your point of view. How do you manage symptomatic endometriosis in a woman who wishes to conceive without worsening the infertility? What do you do in Bahrain, Dr. Basma?
Okay, so I mean, it's a big topic. We talk about it a lot, and then I'm sure that, I mean, it remains a topic that is very debatable, because we not always, I mean, agree on a certain or a specific pathway. And sometimes we have 2 pioneers, let's say, in the treatment of endometriosis, and one would do, I mean, the opposite of what another person would do. And this is mainly where we talk about, should surgery come first or should IVF come first? And this is, I mean, let's say it's a long time debate that we always discuss in conferences. I would say, number one, I mean, what are the surgical indications? Okay, so the surgical indications are always tailored according to each patient. And the surgery, I would say, when we propose a surgery to a patient, it should be a surgery that would do better than what the patient is in now. Because we have to understand that sometimes surgery also worsens the symptoms of a patient. Just as an example, if we have a rectal endometriosis, for example, sometimes a patient can be totally asymptomatic, and we should not forget that a rectal resection can lead to some unpleasant digestive symptoms following that.
Absolutely.
So, yeah, so before starting, I would say that, I mean, what are the symptoms of this patient? Would surgery add more, I mean, or add more benefit to this patient before, I mean, going to IVF treatment? On the other hand, because I'm sometimes maybe being a surgeon, I mean, I'm a pro surgery. If we have, I mean, patients with, for example, huge nodules, and I'm especially talking about rectal nodules, or for example, urethral nodules, we might, by like delaying surgery, what could happen is that those symptoms can become worse. And we have experienced, I mean, cases in which we have delayed surgery because the patient prioritized pregnancy and IVF treatment. And this has led to bowel obstruction and the patient having come to surgery in an emergency situation. So just to summarize, I would say that if the patient, or if there is a surgical indication, it should be tailored according to the patient, and we have to outweigh the benefits of surgery versus delaying surgery, for example, before or I mean after IVF.
While on the same topic, Dr. Basma, what is your experience? Patients come to you, they're sent to you as a surgeon, they have an endometrioma, maybe bilaterally, 3 centimeters. Where is the cutoff? When do you operate, especially when we're talking about infertility? What is the cutoff that now here I can go in and get rid of this endometrioma, or this one I can leave and let the infertility guys, sort of continue? Do you have a criteria in Bahrain?
Okay. So I mean, there is no consensus on the cutoff for operating on endometriomas. Which I always, see with the fertility specialists is that, if the patient is not symptomatic from a endometrioma point of view, because sometimes only endometriomas, remain asymptomatic, and if the IVF specialist is comfortable in, proceeding with the IVF therapy without the need for an endometrioma excision, I would prefer not to excise the endometrioma, especially if they are bilateral, because that would bring the ovarian reserve quite low in a disease that we know is chronic and would recur, just after surgery.
Maybe the other thing is that when we go in for this surgery, we also have to be very careful again, because if you're going to enucleate the endometrioma, we always have to think about AMH and the ovarian reserve later on. And my practice is first, before doing any surgery, is to do an AMH level and then do it afterwards, so that we can have an idea where we are before we go in for IVF treatment.
And that's a similar practice whenever I operate on any patient with, endometriomas. So whenever I touch the ovaries, I always have an AMH, because that also helps in determining whether you can proceed with surgery or you cannot proceed with surgery. So in somebody who has a very low anti-Mullerian hormone, then of course this is not the ideal candidate to even touch the ovaries before going into an IVF treatment. All
right. Thank you. Now, when do we start this leuprolide acetate? Because that's a question here. During the management of endometriosis, other people started before. As you said, in some of your cases, deep infiltrating endometriosis, give it for 3 months, sometimes even up to 6 months before you go in. And sometimes you actually don't need to do any surgery. So what about, what about post-surgery? Because there's a question here. When would you advise that we start using the leuprolide acetate?
So if I understand, the question is using the GnRH agonist prior to surgery,
agonist, right?
Yes. Prior to surgery only, we're talking about it, So all my cases who have deep infiltrating endometriosis, so I talk about rectal endometriosis, bladder endometriosis, urethral endometriosis, or those of the rectovaginal space, I would always use a GnRH at least 3 months before going to surgery. Because, as I said, we don't have any studies, so the studies are very limited, but it is just by experience and by expert experience. We have noticed and we feel that the surgery is less difficult and the tissue is less friable and the inflammation is less. So those are the surgeries in which I would need to go for, deep dissections. So using GnRH always helps before deep infiltrating endometriosis. I do not speak about only endometriomas. If I only have to go for endometriomas, I do not necessarily need to use GnRH prior to surgery, but I would also advise using any sort of medical treatment before surgery, removing an endometrioma and continuing with the treatment thereafter. And this could be approached with any simple medical treatments like oral contraceptives or progesterones. And that is to reduce, the disease coming back again.
Later on. And the duration, I think in one of the slides you showed that you actually used it even for 4 years, 5 years. That lady that you showed?
Yeah, we used it for 3 years, and the lady who had the huge episiotomy scar. So she had no pregnancy desire. And because, it was very huge, So we thought that we would use initially a potent treatment that would shrink the size, and then we continued with progesterones after that.
Okay, I think that is quite interesting. But you also did something else, that you did measure the bone mineral density all the time.
Yes.
Fantastic.
And I think it's an important thing to do whenever we use the gonadotropin releasing hormone beyond the recommended 12-month duration, because I mean, recommended 12-month duration is to reduce the side effects, and especially the important side effect of osteoporosis. So I think if we go beyond those recommendations, the least to do is to measure at least the bone mineral density as a yearly follow-up.
Yes. Add-back therapy, do you use Tibolone, or what do you use?
I mean, there is no consensus on that also. Tibolone is a very good add-back therapy. I do not have it in country here. So what I use is, and I mean, patients find it, they're quite comfortable with it. I just use estrogen as a gel. Estrogen as a gel.
Are you not afraid? Okay, use estrogen, you know, just alone, or later on with progesterone because of endometrial thickness, if you're going to use estrogen alone? What do you think about that?
Yeah, I mean, combined is usually better. A combined add-back therapy is better. And if I use it for longer periods of time, I mean, I do add a progesterone.
All right, right. All right, very good. Jackson Juguna says, great presentation. Which classification system is the most appropriate in terms of description of disease and planning care, comparing ASRM, American Society of Reproductive Medicine, and NZN or Enzyme, whatever it is, depending on where you are? What do you think? What is your take on that?
I use the SRM. I mean, the publications were built on that. I'm not sure if there is one better than the other, because even the ASRM is, as I mentioned it before, it is a staging more of fertility than it is a staging of, let's say, deep endometriosis or superficial endometriosis. So sometimes we have a very high stage, let's say a stage 4 endometriosis according to this staging. But for example, I mean, the fertility abilities of the lady is conserved because the fallopian tubes are open, whereas she has erectile endometriosis, she has bladder endometriosis. So it is a severe disease, but just because the fallopian tubes are patent, her fertility ability is conserved. And so, I mean, maybe you would not stage her as a stage 4.
Maybe just a little bit throwing the spanner into the works a little bit. In times past, some of our senior colleagues would advise patients to get pregnant. You know, it will sort out the endometriosis. What is your take on that?
I do advise my patients to get pregnant also.
Oh, you do?
Because I mean, pregnancy is a 9-month status with no medical treatment. So it resembles the status of a continuous medical treatment. And yes, I mean, most of the patients, if not all of the patients, they are usually satisfied. The symptoms are resolved during pregnancy. Good. Of course, we do have some complications sometimes during pregnancy, but those are very rare.
All right. We go back to adolescence. If an adolescent is diagnosed with stage 4 endometriosis, what are the complications she can expect after surgery? This is from Rose Mwandagina.
I think I think it's very rare I mean, I haven't seen in my practice. I'm not sure if you have seen, Dr. Kariki. I think that stage 4 endometriosis in an adolescent is very rare. If it does exist, I mean, I haven't seen it up to date, even though I see a lot of cases of endometriosis. But I mean, we should be very, very, very prudent in treating those patients. I mean, I would say especially surgically, because in general, we are treating young patients in whom the function should be preserved.
The next 2 questions are also, connected with adolescents, and I think that is an issue, as I said, in a paper which was published not too long ago. Diagnosis, from symptomatology to proper diagnosis, about 10-11 years, and that was in developed countries. It was done in Austria, I think, in Germany, and I think in the Netherlands. Here, another question about fertility in adolescents. And when they undergo surgery and follow up, and how do we deal with these fertility issues, considering their adolescence and we need to sort of preserve their fertility? What is your take?
Okay, so I mean, I said it again, in adolescence, usually we would have the stage 1 peritoneal endometriosis. And usually, I mean, surgical treatment, let's say like therapeutic surgical treatment, is not recommended. So just let me tell you, I mean, the pathway that I usually follow, and maybe most of the physicians also follow. So let's say if you have an adolescent in whom you are suspecting endometriosis, so most probably it would be just a superficial type of endometriosis. So you can empirically start the first line treatment, which is either oral contraceptive pills or progesterones, whatever is suitable. Progesterones, I mean, you have to be careful with what type of progesterone you are using, because some types of progesterones, they also reduce the bone mineral density. So you can start, let's say, with a combined oral contraceptive pill. And then if this contraceptive pill manages to resolve the symptoms, then you can just continue on a contraceptive pill. So you would only go for a diagnostic surgery, so a diagnostic laparoscopy, in those adolescents in whom the first line treatment has failed. Because before putting in, I mean, a potent treatment like gonadotropin releasing hormone with all its side effects, and maybe the side effects of reducing the bone mineral density in a group of patients who is, I mean, at a growing age, I think that thing should not be done empirically, and you should have a diagnosis. So here you would go for a diagnostic laparoscopy, because as I said, I mean, adolescents would usually have only a stage 1 peritoneal endometriosis that you would not be able to see on any imagery, neither on ultrasound and maybe not even on MRI. So here you would do a diagnostic laparoscopy, you would visualize the spots, you can take biopsies, for example, to confirm your diagnosis, and then you can go for a second line treatment, which is the gonadotropin releasing hormone agonists, which have been recently, I mean, authorized or recommended for use in this age group, of course, associated with add-back therapy. I would not use, I mean, this treatment also for very long. So the articles or the recommendations tell us that we should use them for 6 months or a maximum of 12 months. So if we need to use them, that's what I would do, because those are the more potent ones that would, I mean, regress the disease, and they would really reduce the inflammation. But following that, once we maintain, let's say, a symptom-free young girl, then I would shift into a continuous medical treatment. And that's also our choice, whether it is a contraceptive pill or a progesterone pill.
The oral contraceptive pills are very controversial, especially in this part of the world. I don't know how it is in Bahrain. Are they, must you get parental, you know, sort of agreement that yes, my daughter can use, you know, contraceptive pills? Because the perception, the notion is that contraceptive pills are for, you know, once you start taking them, sexual promiscuity, etc., etc. Some quarters don't actually even think about oral contraceptive pills as medicine per se. And here we are talking about oral contraceptive pills as the first line of treatment in adolescent endometriosis. Do you have any issues with that in Bahrain?
Yes, I mean, I think it's something which is, of course, cultural in our country. So, I mean, all adolescents would come accompanied by one of the parents to clinic. They rarely come by themselves. So there is always a parent. And yes, of course, I mean, I had difficulty when I first came back from France, because, I mean, back there in Europe, oral contraceptives are started as early as maybe the age of 15 for reasons of contraception. And they would continue with them till the age of 30 until, I mean, she decides to maybe get married or have a child. And this is something that, of course, would not happen. And it would be shocking to the society to start contraception at an early age, and not even at an early age, because I sometimes have even girls at the age of 20s and 30s refuse taking contraceptive pills. But this is where I think that, I mean, awareness starts. So I would always spend more time, I mean, with the mother, and I would spend more time also with the young girl in telling them what are the advantages of using this pill. Because, I mean, if they go also and read, and if we tell them what are the complications or the progression of disease usually they get convinced at the end. So at the beginning, yes, I had difficulty, but now with awareness and talking more to them, spending more time telling them that, I mean, the advantages of taking the contraceptive pill outweighs, I mean, the disadvantages of the contraceptive pill when we compare it to the complications that can occur because of what? Because of endometriosis. And this is where I talk more also about fertility, because usually fertility is a very important topic for the mother. It's something very important for a young girl. So when you tell her that, I mean, this contraceptive pill does carry side effects, I sometimes tell them that even a paracetamol has a lot of side effects. So, but when we see the advantages that this pill can carry for this young girl, instead of not using it and maybe coming years later with a stage 4 endometriosis, they usually accept the concept.
Maybe just one example before we go to the last question. A colleague of mine, I think it was last year, told us of a very difficult endometriosis case he had. An adolescent girl, 14 or 15 years, with severe endometriosis, who had bleeding from the ears, bleeding from the palms, and also from the joints, knee joints. I mean, a horrible, horrible case of endometriosis. He had tried everything, GnRH, agonists. He had tried, oral contraceptive pills, progestins, and so on. Are there any other new molecules that can be used in your experience in endometriosis that you know of?
Yeah,
Yes.
but I'm not sure if there are any molecules that would do better than a gonadotropin releasing hormone agonist, because that is supposed to be the most, potent when compared to other medical treatments like contraceptive pills and progesterones. There are the aromatase inhibitors, but personally, I don't have an experience. I have never used them
not widely used, actually.
Sorry?
I'm saying they're not used very widely.
Yeah, that's what I said. We know about them. We know that they exist, but I have not used them personally. But it is a little bit, of an unusual case.
Very unusual.
It's very unusual because I have never seen endometriosis in the ears, neither in the palms.
Yeah, unfortunately. The last question is from Rose Mwandagina, sorry. How do you cope with stage 4 endometriosis, and does it worsen with age? What do you think? What is your take?
We have to know that endometriosis is a chronic disease. So if it is a chronic disease, it means that, yes, of course, it can worsen with time. And since this patient has reached to a stage 4 endometriosis, then it means, of course, that, as I said, she was not born with this stage 4 endometriosis. It means that at some point of time, she had very minimal lesions. She had only maybe a superficial or a peritoneal endometriosis that has managed to progress into a stage 4 endometriosis. So yes, endometriosis is progressive. And those patients, not only those patients, but any patient with endometriosis is a patient that should not be left out in the nature, even if we start any medical treatment. But those are the patients that, even with medical treatment, should have continuous follow-up. It's a chronic disease, just like diabetes and hypertension, and they should have follow-ups regularly. How would we treat stage 4 endometriosis? As I said, it all depends on where the lesions are, because saying stage 4 endometriosis could mean a lot. It could mean rectal endometriosis, it could mean bladder endometriosis, it could mean urethral endometriosis, vaginal. So all depends on where the lesions are localized. What are the symptoms that are bothering the patient, and the treatment is tailored according to the localization of the nodules and the symptoms.
Thank you very much, Dr. Basma. Thank you for the questions. Thank you. It has been a very invigorating session. The take-home message that I get from here is that obviously we know that this can sometimes be a very difficult and complicated disease, can affect our social, physical, and even our sexual lives, as it were, of the patients. It can be treated again, medically, surgically. And again, something interesting that you mentioned in your talk is that deep infiltrating endometriosis, first of all, treat with a GnRH agonist before you consider doing surgery, which is something I think we can refresh and remind ourselves about. Apart from that, the issue of contraceptives, which we pointed out, it's good to talk to the patients and explain to them that, yes, in as much as this is what it does, these are the possible side effects. Downstream, the positive sides are more because the fertility will be preserved. We will be looking forward to hear about the results of your measure. Measure, you say it in French, measure? Measure. We learn about your measure trial. It will be interesting to see how the results pan out between the surgery and between the medical treatment. We want to thank you for taking your time to share with us your knowledge and your experience. We are very happy about what we have learned this evening, and I'm sure our participants are also very happy. The questions and the caliber of the questions that they sent shows that this is something which we are very interested in, because we see these patients almost on a daily basis, or if not on a weekly basis. And I hope that we'll have another session with you, not in the near future, shortly, Dr. Basma.
Thank you very much, Dr. Kiriki. It's my pleasure to be here, and I also had a very wonderful night spent with you.
Au revoir, Madame Docteur.
Au revoir.
Thank you very much. I'll hand this over to Prashant to give a few remarks. Thank you very much, Dr. Basma. Bye-bye.
Thank you, Dr. Kiriki. Thank you, Dr. Basma. It was really a very nice engagement with you tonight. And I thank you for a very, very beautiful presentation. It was straight on the point. And it addresses day-to-day issues, which our doctors faces in using the GnRH agonist. In Kenya, we see our doctors, they are more shy in using this category of drug. And I think your presentations will really help them boost their confidence to use this drug more frequently. Dr. Kiriki, thank you so much. You engaged very nicely. You handled all the questions very nicely. And I think your inputs together with the questions from the participant was also very much helpful. I also thank all the participants who gave us this kind of questions to engage our moderator and speaker in a fruitful way tonight. So on behalf of Bharat Serum team, I thank you, Dr. Basma and Dr. Kiriki, for your time and your valuable insight. I also thank all the participants for taking their time out and attend this webinar from us. Our association with COGS will remain, and we have a monthly webinar every month, and we'll continue engaging all of you with new topics. So on behalf of Bharat Serum team, thank you each one of you. We really appreciate your participation, and with the permission of our moderator and speaker, if they're in agreement, we can call it off now.
Thank you very much. Yes, we can. Good night, everybody.
Thank you, sir.
Yes, we can end the session. Thank you. Thank you, Dr. Basma. Thank you, Dr. Kiriki.
Thank you.